Assalamu alaikum. Good afternoon. Uh, Thank you, GIS and lecturer, for having me. My name is Hassan Harbi, one of the cardiologists and intervention cardiologists, King Saud Medical City, Riyadh. And I'm going to talk about some practical cases and specifically in acute MI and using Bioadaptor. As we know that when we think about MI, usually it comes to our subconsciously that the people who's coming with MI usually in their 60s or 70s. But when we see our data, which is actually in the Middle East, we get 1 year, one decade earlier in these people, so we get an MI earlier. And usually when they get an MI, one of every 10 patients, they get an MI in age of less than 40. And this is also confirmed in registry in the other area of Middle East. And this is confirming one of the large SS Surveyor, which was done by STAR's program, showing that the people in our region, and specifically in Saudi Arabia, they get an acute coronary syndrome in age earlier, around 56, which is this for sure, including people who's in 70 and 60, but the mean come down to be 56 because they're including younger people for sure. And the same for the people who's in other region in Oman and UAE. They found that the people around 7 to 8% to have an MI in younger age. And our young people is not in a low-risk group. They tend to be diabetic and smoker and obese. For that, they're not carrying the conventional risk. So again, the question was, is this device matter for the age? We can say that for the people who's 70 to put on a conventional stent, it will perform well for 5 to 10 years. But the people who's coming in age of 40 to 45 and you put on a stent for them, they need to live longer with this stent. And as Dr. Khalid mentioned about the plateauing of the stent, even the classical stent is not plateauing. Still there is 2 to 4% of annual risk. For that reason, when we think about stenting these young people, we should think about what is the device that can suitable and can live longer in their body. So this is the first case for a 47 years old man who's coming with an anterior MI. It is, as you saw, is a normal crystal clear fizzle in the circ, and this is acute occlusion in the mid of LAD. It was wired and stented with a 3.5 by 23 stent, and being followed up in the OPT, and he's doing so far great. And then this is another case also again of 35 who's a smoker and coming with anterior MI, again crystal clear fizzle, and he had an acute occlusion at the osteal LAD, and I was showing there is no clear landing zone at the osteal and should go all the way to the left main. In young people, again, who have to stent all the way back to the left main. So for that was stented all the way to the left main and optimize it and having a good result. And this patient follow up so far 6 months in the OPT, and he's doing great. And the third case I have for the patient 47 who's diabetic and smoker coming with anterior MI and shocky, and again was using the same long stent, and as they mentioned earlier, the choice of long lesion in diabetic and LAD, it fulfilled at least the criteria for using that one. And again, the patient had the stent, and he was doing great after that. So again, this is what's been mentioned by Dr. Sultan, the Infinity Suite Heart study, which is comparing the dynamics with the DAS Onyx, and it's been followed up at 6 months. And it was clearly including our population, which is the STEMI people, and around 25 in each arms. And clearly the story start to be after 6 months to be defeated from each other. and this is where the DAS stop, and the classical DAS after 6 months, and the recaging is starting by polymer reabsorptions. So the question, and I think this is what my message we should come from this talk, is this fitting to our population? We saw that this is predominantly involving the Scandinavian people, 70 years old. Late benefit after 6 months was already clear. But in our people whose MI is earlier than 10 years and reduce the event, is this device matter for them? And this is my thinking and my approach at that one. We should, not every patient should get a bioadapter. We should select our bioadapter for the people who having the younger and high risk anatomy, has been mentioned in studies. And for that, we should also start our data for bioadapter for younger people. And also we need to integrate that for sure with the secondary prevention. Device alone is not an a story to win. And finally, I think presenting our original data and GIS and SASIS and other forms with the reimbursement pathway, this is the way what we can a bioadapter selected in high subgroup. And thank you so much.